The other thing that would concern me with this would be ectopic pregnancy or angular interstitial cornual, basically pregnancies that are not in a place where they can grow safely. Dr. Whedon, since you do IVF and that is a known complication that can happen and you're screening so early in these pregnancies, can you explain to people when do you know where it is, and how do you decide if it's in a place where it shouldn't be? Because sometimes they can go to those places and have a heartbeat.
Yeah, absolutely. So I think, one of the first and most important things when we're talking about ectopic pregnancies is just to understand what the word ectopic means. Many people associate ectopic with a tubal pregnancy. That's true in like 96% of cases, that an ectopic is usually in the fallopian tube. When the egg is released from an ovary, it has to be picked up by the tube. Sperm in standard conception, of course, goes up through the cervix, which you access through the vagina, through the uterus, out to the tube. And that's where egg and sperm meet. And that's where conception typically occurs, in spontaneous conception. For a myriad of reasons, that little embryo can get stuck. And that is what happens in a tubal ectopic pregnancy, is for whatever reason, it doesn't continue traveling. And there are quite a few risk factors for that, which I can mention in a moment. But that is what is defined as an ectopic, or a pregnancy that is outside of the proper uterine structure, or the endometrium, the lining of the uterus. So in 96% of cases, that tube is where we would find that. It is a place where an embryo cannot live, cannot survive. It's about 1 millimeter wide. So if you can imagine, you put a little growing thing inside of a small space, at some point that is going to outgrow its space. And so that's why ectopic pregnancies, in particular those in the fallopian tube, but anywhere, are so dangerous, because at some point that ectopic is going to outgrow its space and break through that structure. And that's where hemorrhage can happen. Hemorrhage meaning loss of massive amounts of blood. Ectopic pregnancy and rupture of is the most common cause of maternal morbidity or mortality, specifically death, in the first trimester. And that's huge. And so when we're talking about these bills and my ability to care for ectopic pregnancies, and many people may say, oh gosh, well, there's going to be an exception for that. Let me talk about that in a moment, but it's huge. That is a huge impact. And then it also, maternal mortality overall is about 4% of maternal deaths. So the word ectopic, meaning outside of the uterus, fallopian tube is the most common location, as I've mentioned. Other locations it can exist, though, and that actually is an area where I spend a lot of time because they're quite rare. Dr. Patel and I both probably see the majority of those. They can happen in the C-section scar in a woman who's had a prior C-section. They can happen within the ovary. They can actually happen anywhere in the abdomen. That's called an abdominal pregnancy. Those actually get identified really late, typically, because there's no restricting space like that tube I just mentioned. So being aware that they can happen, in my patient population, we're looking really early. We kind of talked about that with regards to pregnancy test and heartbeat. But there is a threshold at which I can diagnose an ectopic pregnancy. And by diagnose, I mean definitively say, I see a heartbeat. It is outside of the uterus, wherever it may be. That is a diagnosis that's definitive. I can see a heartbeat. It's outside the uterus. That's defined as an ectopic. And then my management options at the moment include surgery, medication management with a medicine called methotrexate, or expectant management, with most cases of having a heartbeat is not actually a reasonable one. Even medical management typically would not be. But a lot of those patients actually present to my office. Number one, I should mention heartbeat is not actually as common as you'd think with ectopic pregnancies, but it happens. Right now, surgery is an option for them, short of when they're medically unstable. And that's something that, each of us knows and learned very vividly in our training. But you don't sleep on an ectopic, meaning they're stable until they're not. And if you just remember me talking about risk of maternal mortality or death from this, it can happen really fast. And so when I've got a patient in my office, and of course in my office, this is a pregnancy that was highly desired. I'm looking at this little teeny fetus that is in the wrong place. Number one, it cannot be moved, which is something that legislators have proposed.
We have no known medical
That's not
treatment
possible.
for
If it
moving a
was,
pregnancy.
I would do it every time, but it's not. And so then I'm talking with my patients about, well, what are our options for management? Because this is a life-threatening condition. If with these laws, as you stated, this most recent one, I'm having to wait until she's medically unstable because there's a heartbeat, that is a bad situation to be in. And I mean, I wouldn't wish that upon my worst enemy, not to mention massive blood loss. I mean, you can get in a sticky situation fast. And so heartbeat's a big deal for ectopics. Selection of treatment is a big deal for ectopics. But there's a whole bunch of gray area between not being pregnant and diagnosed ectopic. This is a whole section of medicine that I take care of called pregnancy of unknown location, which is the heavy lifting of what I do with early pregnancy complications, if you will. And what I mean by that is those are the really confusing ones. They are hard for patients. They are hard for doctors because I've already mentioned the risk of an ectopic is so grave. If I don't know where a pregnancy is because it's too early, those little teeny cells are just growing and dividing, but maybe they're not growing and dividing normally, but they're still growing and dividing. It may not develop a heartbeat and give me a clear understanding of where it's located. And what I mean by that is it could be in the uterus, but it's not normal. So it's not going to result in a live baby, but it could still be in the tube because I can't see it for sure. And those are another scenario of, as we've talked today, exceptions, ? Impossible to define them all. But yet still very dangerous to our patients.
Yeah. And the other barriers, that I can foresee too, is that with the political debate surrounding abortion is, as we said, about 70% of them are performed with medications, access to things like methotrexate, misoprostol, mifepristone, are certainly things that could happen as well that could delay treatment for patients.
And shortages of those medicines. Methotrexate is an incredibly important medicine for ectopics. It's also an incredibly important medicine for a lot of rheumatologic conditions. Rheumatoid arthritis is one of them. And so, we have kind of talked about this on a lot of different stages separately. In one of our, we're working towards gathering other Nebraska physicians that understand that this can impact a lot of other areas of medicine. If you're somebody that needs methotrexate on a regular basis for your rheumatoid arthritis, well, this is important for you too. Access to medicines that are important for other conditions is huge.